Welcome to the Deep Dive. Today we've pulled together a stack of specialized medical sources, and we're on a mission to get a really quick but expert-level understanding of one of the most fundamental processes in our bodies,
Yeah.
oxygenation. We want to go beyond the basics, to really understand the mechanics, the vulnerabilities, and maybe most importantly, why this whole process can be so different depending on your age.
That's exactly right. I mean, you think you know what breathing is, but then you start to break down the system of oxygen delivery and, well, its complexity is just stunning. So for this deep dive, we're really focusing on two things. First, defining that core delivery system. And then second, looking at how some specific high-stakes conditions, the sources call them exemplars, like asthma or cystic fibrosis and RSV, how they directly challenge that process.
Okay, so let's start at the very beginning, because the terminology here is, well, it's really precise. When we define oxygenation, our notes make it clear this is the big one, the overarching process. It's fundamentally about providing oxygen to, and this is the key part, all cells in the body. It's a delivery service for the whole system.
Precisely. And the system's function is all dictated by that cellular demand, the whole cascade, taking in air, getting it into the alveoli, those tiny air sacs, and then making sure that oxygen diffuses into the blood. That whole journey is just there to satisfy the cell's need for fuel.
So if oxygenation is the delivery service, then we should probably clarify its very close cousin, respiration. From what I gathered, respiration is just the exchange part. Oxygen in, carbon dioxide out. One feeds the body. The other is about keeping that vital gas balance. It's easy to mix them up.
It is, but they are different stages. And what's important here is that a lot of the conditions we're going to talk about, they disrupt the environment where that diffusion, that respiration happens. And that immediately limits the entire systemic delivery, the oxygenation.
Okay, let's unpack this then. Because if we're looking at respiratory distress, especially in a clinical setting, a patient's age is like the first critical variable. Our sources really hammered home the anatomical differences between children and adults, and this is where it gets really interesting for you as the learner.
The differences are profound. I mean, the reason pediatric respiratory illnesses can escalate so quickly, the central issue really comes down to proportional size and structural integrity. Children have shorter, narrower airways, period.
And when you just stop and visualize that, the implications are huge. So an adult airway, it's pretty wide. A little inflammation, maybe some mucus, you lose, what, 10% of the volume? But in the baby's airway, which is already so narrow, that same amount of inflammation could mean you lose 50% or more of your space.
That's the key insight, yeah. The effect of inflammation or mucus is amplified exponentially. It's like the difference between a small leak in a big garden hose versus a tiny leak in a drinking straw. The disruption to the flow is immediate and it's severe.
And it's not just the size, right? It's the structure itself. The notes pointed out that the cartilage supporting the airways is just more flexible in kids, which seems like a vulnerability, especially if a child is breathing hard.
It is. That flexibility can lead to what we call dynamic airway collapse. It makes their breathing less efficient, particularly when they're trying to take a deep breath in. And then you add to that the fact that kids have an immature musculoskeletal system, those intercostal muscles.
The ones between the ribs.
Yeah, the ones you need to expand the chest. They just aren't fully developed yet.
Wait, so not only are they breathing through a much narrower straw, but the bellows, the thing powering the breath, aren't as strong. That sounds exhausting.
It is exhausting. And all these factors combined mean children often have to use a much greater effort, a higher metabolic load, just to maintain decent gas exchange compared to an adult. So they fatigue much, much faster.
And just to kind of complete the picture of the developing lung, the sources also confirm that the alveoli, the actual place where the gas exchange happens, they're still developing too. They increase in number and size all through childhood. It just explains why age isn't just a number here, it's the state of the hardware itself.
Okay, so let's shift gears a little and look at the challenges to this system. The source identifies several exemplars, as they call them. These are conditions that lead to respiratory distress or hypoxia. We can start with asthma, which is that classic airway hyperactivity problem. And I think while most people just think inhaler, the strategies are actually way more comprehensive.
They really are. Looking at the treatment protocols, you see a really broad spectrum. On the medication side, yeah, the notes list anticholinergics and steroids. We know steroids are for inflammation, but the anticholinergics, I think those might surprise people.
They help relax the smooth muscle tissue around the airways. It's another way to help open up those smaller passages. But treating asthma is always this balancing act between immediate relief and, long-term control of that chronic inflammation.
But I thought asthma was mainly about those quick relief bronchodilators.
Yeah.
Why would something like deep breathing and coughing techniques be listed right alongside serious medications?
Well, because the problem isn't only muscle constriction, it's also mucus trapping and air trapping. Deep breathing exercises can help improve how well the lungs are used, and a good strategic cough helps clear out all those secretions. It shifts the focus from just pharmacology to, well, physical mechanics.
And this is where the sources threw in a fascinating detail that really shows how holistic the care is. They include vests, as in physical therapy equipment, not just a way to deliver medicine.
Yes, exactly. They're often called high-frequency chest wall oscillation vests. They literally shake the chest to loosen mucus, making it easier for the patient to cough it up. It just underscores that for oxygenation to work, the airways have to be clear enough for gas exchange to even happen.
Okay, moving to the next big exemplar, cystic fibrosis, or CF. This one. This isn't just a respiratory condition, it's profoundly multisystemic. This is the one that really forces you to think about oxygenation systemically.
Absolutely. If we connect this to the bigger picture, CF is a textbook example of how a microscopic failure in one single protein can just cascade into a systemic disaster. The core issue is the absence or dysfunction of the CF transmembrane conductance regulator protein, CFTR.
That's a mouthful. So what does that protein actually do that makes it so important?
In simple terms, the CFTR protein is a channel. It regulates how chloride and water move across cell membranes. When it's broken or just not there, that fluid movement fails. So in the lungs, this means the mucus layer becomes incredibly thick and sticky. It just traps bacteria and leads to chronic infections and obstruction.
I see. So the problem isn't the lungs themselves, but the transport system that's supposed to keep all the surfaces lubricated and clear. And that failure causes thick secretions everywhere.
Precisely. And because the CFTR protein is active in so many other organs, the pancreas, the liver, the intestines, the consequences are widespread. The source really emphasizes that it affects multiple systems and organs, which right away tells you why the treatment has to be so complex.
Because CF is systemic, the treatment has to be systemic too. The protocols go way beyond standard respiratory care. You see the familiar stuff like antibiotics and bronchodilators to manage the lung part.
But then you add the component that's really transformed life for CF patients, CFTR modulators. These are high-value details because they don't just treat symptoms, they're designed to actually fix or at least improve the function of that faulty protein itself.
Wow, so that's the game changer, addressing the root cause. And the digestive element is fascinating. Since the thick secretions also block the pancreatic ducts, the digestive enzymes can't get to the food.
Which is exactly why the specialized diet is so critical. Patients need to take supplemental pancreatic enzymes to help them digest. Plus, a very specialized diet that's high in calories and high in fat. It's because they just can't absorb nutrients efficiently. It's this constant battle to maintain weight and energy, which, in turn supports the energy they need just to breathe.
It's just incredible. A high-fat diet being directly tied back to a protein malfunction that's also blocking up your lungs.
So let's touch on our final exemplar, RSV, or respiratory syncytial virus, which often leads to bronchiolitis in infants. It sounds like just a common virus, but for those anatomical vulnerabilities we talked about earlier, it can be devastating.
Right. An adult gets RSV, it feels like a bad cold.
Mm.
For a 2-month-old, it can be a full-blown emergency. And our sources really connect the dots right back to that vulnerable pediatric anatomy.
Exactly. The inflammation from RSV settles in the smallest airways, the bronchioles. So, given in infants already narrow air passages and that flexible cartilage that offers less support, that inflammation creates massive obstruction and air trapping. They're essentially trying to breathe through airways that are severely inflamed and can easily collapse.
So what does this all mean when we put it together? The sources give us a really comprehensive toolkit here. We can now look at a diagnosis, whether it's inflammation like asthma, a genetic problem like CF, or a virus like RSV, and immediately understand how the anatomy in children just amplifies the danger. Small structural differences lead to these huge clinical consequences.
And if we summarize the core takeaways for you, first, the mechanics of oxygenation. It has to be understood as that systemic process of delivering oxygen to all the cells. Second, those critical anatomical differences in children, the narrow, flexible airways, the immature muscles, they make them so much more susceptible to distress. And finally, conditions like CF demand these multifaceted systemic treatments because the root cause, that protein malfunction, affects the body far beyond just the lungs.
We started this deep dive by saying oxygenation is the universal process of getting oxygen to all cells. And then we explored cystic fibrosis, noting how a single protein failure leads to thick mucus, not just in the lungs, but also blocking the pancreas, which means you need special enzymes and a high-calorie diet. So this raises an important question for you to maybe mull over. If the fundamental driver of illness is often a failure to get oxygen to all tissues, and CF shows us how one microscopic malfunction can sabotage multiple systems at once, the lungs, the gut, the liver, how many other seemingly isolated respiratory conditions have these critical non-respiratory components that we might overlook, but which ultimately determine the patient's long-term outcome? Something to think about and maybe explore on your own.
Thank you for joining us for this deep dive. We'll catch you on the next one.